Hello? Can you hear me, Nicole?
Can you hear us?
Hey, yep, hear you now.
Yay. Okay. Oh, sorry.
Okay, y'all saw the invoice that you use differently? Okay.
Sorry. I'm trying to
They're working now?
I think so.
It would after I went and got my legs. Huh? I have them all over my house, different sizes. Ow! Turn your thing off. Microphone.
You ready to talk to me?
No, not you.
Oh, I can mute people if I need to. Not Katie though. Whoops. There we go. Since we're on her computer, right?
Oh, well, it's her email. What we're gonna have to do, and I'll get to work on that, is set up a dummy email just for this. Because otherwise, if like logging into my email, whenever if it goes in and out, then it shows my email up on the screen or whoever email we're logged into. Does that make sense? So, but I can get a dummy email account set up just for this, so that no email goes to it but that.
Can you hear us?
Yeah.
Who's the user? Some poser here, isn't it?
I've got 34 logged in, but that might be everybody. I don't know. Because we've got a handful in there, right?
Oh, I wasn't logged in.
We've got 50 something now. Oh, I know mine.
I don't need everybody logged in.
We don't count, we'll be all right.
Okay.
My job here is done.
You think you knocked it out, huh?
I'm going to take my legs and leave.
Do it.
Oh, I know all there is to know.
Okay, 3:15. You guys ready?
Yeah.
Okay, let me see if I'm ready. Is that up on your screen, the PowerPoint? Is the PowerPoint up on your screen?
Yeah.
Yeah? Okay. Not me, right?
Right.
Okay.
Is it this one? That guy? Show small. Oh, sorry, I'm doing it with my wrong hand. Is that better? Well, do you want to see him, or you need to get him and everybody?
All right. Okay, we're ready to go? Yeah?
Yeah.
Yeah, okay. All right, so yeah, I've been told by a few people that the answers to the workbook have, they've all run out. So I'll be working on that, and I'll get those uploaded hopefully in the next day or so. I'm not gonna leave you hanging. Any questions about the quiz or anything? I guess since I've got some verbal feedback today, anybody have anything they need to throw out there? Grades haven't been posted yet, I don't think, right? No? Yep.
No, they have not.
Okay. Most people did really well. I think they'll be up soon. All right. So the last week we talked about axis and bundle branch blocks. So now we're going to move into the fourth category of EKG interpretation. So we have rate, rhythm, axis, and now we're going to talk about hypertrophy. So we've gone over hypertrophy in pathophysiology. Basically just means an abnormal enlargement of the heart muscle. So we'll talk about how you can detect that on the EKG and try to sort things out. Now, EKG is not the best test for identifying hypertrophy. It can kind of give you some clues or some suggestions that maybe that's going on, but it's not always completely reliable. Not always sensitive and not always specific, as we'll talk about. So we'll get into that in a minute. What do we think the best test is for checking to see if somebody's got hypertrophy? Everybody. Did I lose everybody?
Oh.
No.
Echo.
Sorry, I'm getting there. Okay, what do you think about an echo? Somebody said echo? You weren't talking about me echoing in the room. You're talking about the test, right? Okay. So yeah, an echocardiogram. Echocardiogram is the best test for that. So we're going to talk about hypertrophy today. So hypertrophy, as you may remember, can happen to really any part of the myocardium. It can be the right or left atrium. It can be the right or left ventricle. It can be multiple parts of it. And all that is usually an attempt to try to compensate for a problem that's going on. So we talked about left ventricular hypertrophy, enlargement of the myocardium. All those things are because the systemic pressures are too high. It's trying to overcome that resistance that it's meeting. Just kind of like going to the gym and working out. as you train with heavier and heavier weights, the muscles hopefully will respond. And so the same thing here with the heart, the myocardium, the stronger the pressures it's having to go against, it will abnormally enlarge. Now, the problem with that tissue is it's not always normal tissue. You can get a lot of fibrotic stuff going on in there, and that tissue does not stretch out normally, does not contract normally, and so then you end up with, even though it's a larger heart muscle, a heart muscle that does not pump effectively. And so that's what we're talking about with hypertrophy. You're right. So the EKG in hypertrophy really is not providing you with a definitive diagnosis. It's going to give you some clues, especially if you got a patient comes in with hypertension and you're wondering if this guy's had it for a long time. You might be able to do an EKG, see evidence of what might be left ventricular hypertrophy, and kind of draw some conclusions that, yeah, indeed, maybe that's what he's got going on. If you want to order an echocardiogram to kind of work it up further, then you can do that. So we'll see that the EKG can provide some information not only about the atria, but also the ventricles, and we'll go over that. So the atria, we all know this by now, hopefully, that atrial depolarization is identified on the EKG by the P wave. So if we want to see if there's an atrial abnormality, then we'll see if there's atrial hypertrophy, then we're going to look at the P wave to evaluate that. Now, really the two best leads to kind of look at the P wave and get the most information about it would be lead 2 and lead V1. Does anybody want to venture to guess why lead 2 is usually a good lead to look at for the P wave?
Didn't hear you.
Okay, so lead 2 and lead V1 are the two best leads to evaluate the P wave in. Why do you think lead 2 would be a good lead to evaluate the P wave?
Direction of depot.
That's right. The main direction of depolarization. So last week we talked about axis. The main axis of depolarization with the atria is down to the left. You've got the SA node that sits in the upper posterior right atrium. So it's got to come down, it's got to go down towards the left, and that's right at lead 2. So lead 2 is giving a picture of atrial depolarization most directly. It's going to give us the one that's most head-on, right? So that's a good lead for us to look at. V1, why do you think V1 is important? Yeah, maybe a little trickier here, but it is the most right-sided chest lead. The other thing is with V1, we get really two parts of the P wave. You get the initial half, which is upright, kind of showing us the right atrial depolarization, and then the second half of that P wave in V1 is going to be the left atrial depolarization. Kind of like your picture you see down here on the bottom right. Is that showing up on your screen?
Yeah.
Yep, down here. So V1 oftentimes is broken down into a biphasic P wave. So the first half being the right atrium, the second half being the left atrium. So if we want to know if there's right atrial hypertrophy or left atrial hypertrophy, then we can look specifically at V1. It kind of breaks those two parts into two parts for us and can be kind of helpful in narrowing that down. Okay, does that make sense? So some things to know about atrial depolarization. You need to know the normals so you can identify the abnormals. So normal P wave duration is less than 0.12 seconds, and the normal P wave height should be less than 2.5 millimeters. Okay, so make sure you're familiar with that. All right, so right atrial abnormality. The reason we call it right atrial abnormality is because not everything that's going to cause this shape of the P wave is always caused by right atrial hypertrophy. There can be some other things, conduction problems, that might lead to this appearance. But this is what we call right atrial abnormality, or right atrial hypertrophy is what we're looking for. Now, so if you get a problem with the right atrium, it's going to take, if it's enlarged, it's going to take longer for it to depolarize. And so that prolonged depolarization of the right atria leads to this really tall P wave that you can see over here on the EKG. See how tall those P waves look? Yeah. Yep. Okay. See the head nod. I like that. So so these really tall P waves are a sign of a right atrial abnormality. So it can be a chamber enlargement. So the right atrium might be too big. There might be some scarring of the myocardium from a previous heart attack, kind of causing some abnormal conduction to go through there. But we call this a right atrial abnormality. Let's go to the next slide here. So the next thing you see is that a lot of times when we have problems with the right atrium, what's kind of coming into the right atrium? What's dumping into the right atrium? Well, okay. Thank you. Deoxygenated blood, okay, from what? The pulmonary artery? Yeah? Okay. So if we've got a problem, that deoxygenated blood is coming from the, so if we've got a problem here with the pulmonary artery, maybe we've got some problems with the right atrial enlargement, okay? So COPD, pulmonary embolisms, atrial septal defects, those things might lead to a right atrial abnormality. What we'll see is this tall, abnormally tall P wave, and because it's been associated with pulmonary stuff for so long, it's also been given the nickname of P pulmonale. So when you see a tall P wave, people will call that a P pulmonale. That kind of helps you to remember what some of the causes of it are from, okay? So most specifically, not just a tall P wave, but the criteria we're looking for here is an amplitude that's greater than normal. So a P wave amplitude greater than 2.5 millimeters tall, and specifically in lead 2, because it's giving us that most direct wave of depolarization. And so we're looking for that. The other thing is we can look at lead V1 and V2, and we're looking for a P wave in that lead greater than greater than 1.5 millimeters tall. You need something, Dar? The thing about it is that we're going to have a normal P wave duration, so it's going to be less than 0.12 seconds. So it's going to be narrower than 3 small blocks, but it's going to be taller than 2.5 blocks. Make sense? So P pulmonale, right atrial enlargement, we're looking for a big, tall P wave. That's pretty much all there is to it. So here's an example of, is my cursor showing up on the screen? Yeah?
Yeah.
Okay. So here it is in lead 2, and what you're looking for, again, it's going to give us the most direct wave of depolarization are these really tall P waves right here, greater than 2.5 millimeters. So you can see that lead 3 has got really tall too. These inferior leads, all those are kind of down towards the bottom, are going to have big, tall P waves as well. But the one you're going to make the measurement in and look at, if there's any question about the diagnosis, is lead 2. Same thing here, it's a little fuzzy, but you can see lead 2, really big, tall P waves, almost as tall as the QRS complex. And same thing over here. You can see those big P waves where it's biphasic. Greater than 1.5 millimeters in height in that lead. Any questions about right atrial abnormality, right atrial hypertrophy? Big, tall P waves and lead 2. That's the bottom line. All right, so left atrial abnormality, same thing here. This is going to be probably more common. You're going to get an enlargement of the left atrium, and so so that will lead to this abnormal appearing P wave. It's also been associated over the years with rheumatic mitral valve disease, and so this particular P wave morphology was given the name P mitral. So you might see that out there. P mitral, so this is the opposite of the right atrial abnormality, where we have big, tall P waves. So instead of this increasing the height, what we're increasing here is the duration. So these P waves are going to be abnormally wide and sometimes have a little notch in them, like you see down here. We'll have a notch in the P wave. And that particular P wave shape, that wide P wave, is called a P mitral. So the specific characteristics we're looking for is a prolonged notched P wave, and again, we're looking in lead 2 because it's going to give us the most direct wave of depolarization. So one is greater than its normal duration of 0.12 seconds. If you're looking at this bifid P wave, that's what we call it, where it has the notch in it, and you're looking for a greater than 0.04 seconds between the 2 peaks. I think that'll show up a little bit better on the next slide, but basically there's about a full block in between this peak right here. See that? And that peak right there. There's almost a full block between the two. Okay. If you look in V1, which generally we look at for these P wave abnormalities, what you'll see is that that second half of the terminal negative deflection that's right here, okay, is going to be greater than one small block in width or greater than one small block in depth. And so that's your P mitral. Remember, the second half of that P wave is your left atrium depolarizing. So that's why we're looking at that terminal or second half of the P wave in V1. It's giving us the information about the left atrium. So if it's abnormally wide or abnormally deep or a combination of the two, then we've got a left atrial abnormality, left atrial hypertrophy. Here's another picture of the P mitral, the abnormally wide bifid or two-part, two-humped-notched P wave. Between the two, you've got at least one block, and then this is going to be abnormally wide. It's going to be at least 3 blocks wide or more, so greater than 0.12 seconds in duration. Here's a side-by-side, right atrial abnormality, big tall P waves, left atrial abnormality, notched and wide. Questions about atrial abnormalities? Not super common and not super worrisome, usually. However, we start talking about ventricular hypertrophy. These can be clues that to that, because if we've got an abnormally large ventricle, it can lead to an abnormally large atrium. So these kind of can help us to build up some information about that. And we'll break that down. Any questions about the atrial abnormalities? Nope. Okay. Moving right along. Very short lecture today. All right, so hypertrophy. One of the things we'll see with ventricular hypertrophy is some different things you can see is an increase in the voltage, which we've already seen with the P pulmonale, where you're going to get an abnormally tall P wave. So with ventricular hypertrophy, we're looking at the QRS complex, so we're going to get abnormally tall or deep QRS complexes because of an increase in the voltage. That's number one. Number two, we also brought this up last week, is that you can see a shift in the axis with hypertrophy. If I've got an abnormally large left ventricle, the axis is going to be even further to the right, further to the left. So we're going to get we can get a left axis deviation with left ventricular hypertrophy. If my right ventricle is way too large, then I got extra electrical activity on the right, my axis can shift to the right. That makes sense? Okay. So we get a shift in the axis, a shift toward hypertrophy. The other thing is we'll see our repolarization abnormalities, and this is where the question about the ST-T wave appropriate discordance or ST-T wave discordance kind of comes into play. We'll see that with left ventricular hypertrophy as well. This becomes a really important concept. I brought it up several times before, but especially as we're getting ready to move into ischemia and infarction, these other things that can cause problems with the ST segment, T wave, become very important to make sure that you remember which ones are which and what can happen. And that's what, there's a couple of videos that I'm going to have you guys watch as part of today's lecture that I've uploaded before. And that's basically what those are about, things that will mess up the ST segment and T wave. So this is one of those things. So hypertrophy can cause repolarization abnormalities, particularly the ST-T wave discordance. So sometimes it can be hard to make the diagnosis of left ventricular hypertrophy based on the EKG alone, but the more criteria that the EKG meets, the more likelihood it is that it is truly left ventricular hypertrophy causing the abnormalities that we see on the EKG. So a concept I want to kind of go back and touch base on before we move on through this is R-wave progression. When we talk about R-wave progression, we're talking about the precordial or the chest leads, okay? So normally as those leads start from V1 on the right side of the chest, V2 on the left side of the sternum, and then kind of gradually move their way around to the left axilla, what we're expecting to see with the QRS complex is a gradual change in the picture as we move across the chest, right? So in V1 being the most right-sided chest lead, we get a mainly negative complex. But as we move around into the mid-axillary line, everything becomes kind of upright. Everybody remember that? Make sense? Remember, the main wave of depolarization in a normal heart is going down and to the left, going away from that right-sided chest lead V1, so we get a negative complex. It's moving towards V6 over here on the left, so we get a positive complex, and that gradual progression along there, right? Yep. Okay. Thumbs up. Becomes important because we're going to talk about right ventricular hypertrophy next. And so with right ventricular hypertrophy, we're getting an abnormally enlarged right ventricle, and everything's going to be skewed here with our R-wave progression. For right ventricular hypertrophy, we get an enlargement in the right ventricle, maybe from pulmonary hypertension, pulmonic stenosis, chronic lung disease. All those things are going to increase the pressure that the right ventricle is having to work against, which will cause it to enlarge over time. So what do we look for on the EKG to help kind of make the diagnosis of a right ventricular hypertrophy? So number one, we're looking for tall R waves in the right chest leads. That's not what we would expect, right? Normally the wave of depolarization is going towards the left. So these right-sided chest leads, we'd get a negative complex. But when the right ventricle is enlarged, now we've got big, tall R waves shooting towards the right that are kind of showing us that we've got an abnormal problem here. If we look at the 12 lead, we might see a right axis deviation. Okay, so we're getting an, remember with hypertrophy, we get the axis shifting towards the hypertrophy. The other thing we can see are STT wave abnormalities, especially in these leads like V1 and V2 where the tall R waves are there. You'll see that we get STT wave discordance. So we've got tall R waves, now we've got ST depression and inverted T waves. Tall R wave, you've got ST depression and an inverted T wave. Everybody see that okay? Now, one of the dangerous mimics of right ventricular hypertrophy is what's called a posterior myocardial infarction. And you guys will get into that here in a week or two. But it looks a whole lot like right ventricular hypertrophy. So sometimes those two can be a little difficult to identify. You don't want to miss a heart attack and call it right ventricular hypertrophy, right? So whenever you get to posterior MIs, just make sure you look at and compare these two closely so that you can kind of know the difference between the two, okay? So tall R waves in the right chest leads, right axis deviation, and ST discordance, where you get some ST depression, and inverted T waves, where you get the tall R waves. All right, here's the 12 lead, and you can see that you've got right axis deviation. We know that because in lead 1, we've got mainly negative QRS complex, and then AVF, we've got an upright complex, right? So if lead 1 is negative, then we know, lead 1 being on the left arm, if lead 1 is negative, we know it's automatically shifting over to the right side on that axis, or the x-axis diagram. So we've got a right axis deviation. Then you can see you got your tall R waves in your right-sided chest leads, telling us that that right side is getting all the energy, and then we get the ST depression and inverted T waves over here. Don't see that a whole lot. Right ventricular hypertrophy is not super common, but it's out there. The most specific finding for right ventricular hypertrophy is this QR in V1. Really, you're just looking for that R wave that's super tall in comparison to your Q wave. Maybe if the hypertrophy has been going on long enough, they may have some right atrial hypertrophy as well, and then you'll see that P pulmonale show up in that as well, as part of your criteria. Questions about right ventricular hypertrophy? Okay. So left ventricular hypertrophy, this can come with prolonged systemic hypertension, so long standing elevated blood pressure, the left ventricle is having to work harder. So then we end up with an enlarged left ventricle. The other thing you see is aortic stenosis or aortic regurgitation. It's harder to get that doorway open. Left ventricle has to work harder, or you get blood coming back into the left ventricle, making it having to do more work so that they get an enlarged left ventricle. So with these criteria, again, none of them are exactly super specific or super sensitive, but the more of them that we have, the more likely it is that left ventricular hypertrophy is really going on. The thing that we're going to look for would be, it really doesn't change our R wave progression so much as it is that we just get an increase in the voltage. So the R wave amplitude in the left side or lateral leads just gets taller. There's more energy going towards the left, so we get taller waves in those left and lateral leads. The S waves in the right-sided leads are going to get deeper because of the increased voltage that's there. We can also see an axis to the left, so we get left axis deviation with the left ventricular hypertrophy. Remember, the axis will shift towards the hypertrophy. And then you can also get ST wave discordance. And that's not super evident on this EKG, but I think it is on maybe one of the other examples. So it's not always there, but you can definitely get some ST wave discordance with left ventricular hypertrophy. Probably the most common way that we make the diagnosis of LVH is based on what's called voltage criteria. So as we increase the amount of heart muscle that's there, we increase the amount of electrical activity that's going through that heart muscle. The problem with voltage criteria is that you can get some false positives from it, typically in young, healthy men who you can get an increase in the voltage without there being left ventricular hypertrophy. So the recommendation is not to use these voltage criteria in patients under the age of 40. Otherwise, you can get some false positives using the voltage criteria with those guys. There are lots and lots, if you were to open up your book and look through it, if you haven't already, there are lots and lots of criteria that can be used for left ventricular hypertrophy. Unless you're a cardiac nerd or a cardiologist or working in cardiology, you'll never know all these things. But so I would just keep a couple of them in your back pocket. Here are the two that I recommend you hang on. Number one, this is called Sokolow-Lyon criteria. This is the one that most folks will use. It's been around, as you can see, since 1949, so it's stood the test of time. We're talking about some criteria that's been around for about 70 years. What this is doing is it's adding the voltage in V1 plus the voltage in V5 or V6, whichever is deeper or bigger, okay? And we're trying to see if that is going to be greater than or equal to 35 millimeters of voltage. Okay? So V1 plus whichever is taller, V5 or V6. And you're going to add up all the little blocks that are there and see if you get more than 35 blocks. Okay? And that's the Sokolow-Lyon criteria. So here we got this. If we want to do the Sokolow-Lyon criteria, we want to add the depth of the S wave in V1 plus the height of the R wave in V5 or V6, whichever is taller. Which one looks taller? Just to make sure you're there. I know it's not hard to figure out. V6 looks taller to me, right? So I'm going to add up the number of blocks deep V1 is plus the number of blocks height of V6 and see if it's more than 35. So I've got 5, 10, 15, 20, 25 plus already in V1. And then I've got 5, 10, 15, 20, 25, 30-ish here. So easily got more than 35 blocks there. Does that make sense? I can see you if you nod your head. Yes, okay. All right, thank you. So the other thing is you're looking to see if they have an axis deviation. With a left ventricular hypertrophy, you'll get an axis that shifts to the left. Yep, thank you. So we're looking to see that. Lead one is upright, so we've got something on the left side of that circle. It's either going to be a normal axis or it's going to be a left axis deviation. So AVF is negative. So I'm shooting away from the feet up to the upper left-hand corner, and I've got a left axis deviation, all right? So I've got more criteria that's going to help me with that diagnosis. Make sense? So Sokolow-Lyon criteria, we meet our voltage criteria, plus we've got a left axis deviation. Looks like this might be legit. This may not just be a thin dude. Now, the other criteria that I would say I would remember for left ventricular hypertrophy for practice and for exam purposes is what happens in AVL, okay? So the R wave height in AVL tends to be the most specific for left ventricular hypertrophy. The EKG computer will call this one pretty often, where the Sokolov-Lyon criteria have not been met, but it will find that the R wave in AVL is greater than 11, and your little computer interpretation at the top will say possible left ventricular hypertrophy. And what it's looking at is lead AVL. So greater than 11 blocks, and these are pretty blurry, but greater than 11 blocks in height is the most specific finding for left ventricular hypertrophy. If you were to go back to that EKG we just looked at, and you go back and look at AVL, you can see that it too is greater than 11 millimeters in height. It's about 15, okay? Just a different EKG, yep. Okay, this is another EKG here. So if we're doing the Sokolov-Lyon criteria, you're taking V1, the S wave in V1, plus the height of the R wave in V5 or V6, whichever is taller, and wow, I don't know, that one looks like it's way up there. That's another clue that they maybe have LVH. When the QRS complexes are all falling on top of each other, that's kind of a sign that your voltage is pretty big. So maybe 5, 10, 15, that's almost 20 right there. Even if we were to use this one, 5, 10, 15, 20, we easily got or greater than 35 millimeters, which would fit the voltage criteria for LVH. Looking for a left axis deviation, we got an upright complex in lead 1, puts us on the left side, either a normal axis or left axis deviation. AVF is inverted, that puts us up to the top. And that left axis deviation. So we've got left axis deviation in this patient. And then we look at AVL, which we know is our most specific criteria for LVH, and see that it also is greater than 11 millimeters in height. So we've got 3 different things that kind of pointing to this patient having LVH. The other important thing is the STT wave discordance. This patient's got it. So where we would expect the ST segment to be isoelectric with the baseline, we see that they've got some ST elevation and an upright T wave in these leads with deep waves like that. If we've got a tall R wave, we see there's a little ST depression and T wave inversion over here. Does that make sense? Okay. So some things with voltage criteria that they're really kind of all we have, but they can be some potential stumbling blocks with that. Young, healthy men can have an increase in voltage even without LVH. Let's say you had a woman with mastectomy. Obviously, there's less tissue, so that the voltage will be increased with that. You'll get an increase in voltage with thin patients. Again, same reason, just like a decrease in the amount of tissue. African Americans tend to have an increase in voltage even when they don't have left ventricular hypertrophy. So in that patient population, voltage criteria may be less useful. And you can get a decrease. So you may have somebody that has true LVH, but they'll have a decrease in their voltage because of their body habitus, and so you may not be able to identify it on the EKG. So add this to your systematic approach. You do your rate, rhythm, axis, and then now we're going to add the question of, does the patient have any signs of hypertrophy? All right. That is all I have on the PowerPoint. Questions that you have. And you can take a minute, sit and think and digest it and let me know. Anybody? What? I'm sorry, I can't hear you.
What are we doing?
What are you doing for the
Quiz.
next week's quiz? Is that what you're asking? Next week's quiz?
Yeah.
So as far as I'm concerned, as long as I'm in over the class, I'm going to let you guys do them at home. When Mr. Brown takes over, if he decides to have you guys start doing them back in the classroom, then we'll do it that way. So the quiz over this material next week will be a take it home quiz. Try to contain your excitement. So now, this is not all the material in the quiz. Let me make sure everybody is aware of that. On eMedley, I posted the link to 2 videos that are on YouTube that I created a couple years ago. Yes, they're pretty lame, but they are material that you need to go over, okay? What it does is it's talking about some new things. There'll be some new topics on there that you need to know about, but then there's some revisiting of older topics. What it's doing is it's reminding you of all the different conditions that can cause changes to the ST segment and T wave, and introducing you to a few new ones. I think it's important to do that before you get into ischemia and infarction in the next couple of weeks, because you need to be able to differentiate between those. In the second edition of the textbook that I'm still working on, there's another chapter in that book that goes over these topics. I've uploaded my rough draft of that chapter to the eMedley site so that you have access to it. It's pretty much covering the things that are in those videos. So you can read it, you can watch the videos, but those are things you do need to be familiar with. I would say for quiz purposes, make sure you know the stuff that was in the written chapter, because the videos are a little old and I don't remember everything that's in them, but I would say for quiz purposes, make sure you know the stuff that is in the book. Yep, thumbs up.
Chat.
What?
Chat.
Look at the chat.
Chat. I'll try. Oh man, lots of chat. Crap. Echo right over the atria. Somebody says slide 33. Is this also a left bundle branch block? Is that what we're talking about, Acacia? So no, here's the thing with LVH and left bundle branch blocks. Sometimes they can they can look similar. The main thing here is look for
Next slide.
the next slide.
Yeah. 33 is.
This is not 33. Oh, yes, that does look like it could be a left bundle branch block. Yeah, you do have a small septal wave here, but yeah, it looks like a left bundle to me. Yep, good call. So yeah, ST wave discordance, just to go over that one more time. So several different things that can lead to ST wave discordance. You've got your ventricular rhythms, like a PVC, ventricular escape rhythms. Your bundle branch blocks can cause this. Left ventricular hypertrophy can cause it. And what we're talking about with ST wave discordance is that the ST segment and the T wave are doing the opposite thing of the QRS complex. So in this patient here, I've got a negative QRS complex. And with appropriate discordance, what I'm expecting to see is ST elevation and an upright T wave. So if you look at the baseline here, you see the ST segment is up and you have an upright T wave. That's appropriate discordance in that situation. Now, if I've got it over here, I've got a tall R wave, so the ST wave discordance would mean it's doing the opposite thing of my QRS complex. All QRS complex, I'm going to get ST depression, which I've got, in an inverted T wave. So the ST segment and T wave are going in the opposite direction of the QRS complex. Okay. Because if you're not aware of that, you'd look at this in the next week or two, and you're going to call this patient having a STEMI or heart attack, and you'd be wrong. Or if you were to look at this one and see the ST depression, you might call it ischemia, and you'd be wrong. So just needing to know when it's normal to see that and when it's not normal to see that. And that's what those videos will cover in that chapter will cover. Any more chat that I'm missing? Here we go. Oh, slide 14. Yeah, so the notched P wave that you'll see with P mitral, the one that's here, we're talking about that in lead 2. Okay, so the notch is going to be seen in V2. I mean in lead 2. This part here, both of these are in lead V1. So it's not listed on there, but you know what? V1. Both of these right here. Huh. Look at that on the fly, man. Okay, so both of these are in V1, and so you're not going to get a notched P wave. You're getting the biphasic or P wave right there. So one that you get the upright portion and the terminal portion. So that's what you're looking for here on that is that terminal deflection. Yes, this is a really long PR interval. I would say that they've also got a first degree AV block in this right here. So both can be true. So what's happening physiologically that causes the T wave to be opposite of the QRS complex? It's probably more than I understand and can probably go into. It's an abnormal. You've got abnormal depolarization in some way, whether it be because there's a bundle branch that's not working, or it's coming from the ventricles and the His-Purkinje system's not working normally. So you end up with an abnormal repolarization in those situations. And so you'll end up with this funky ST elevation or depression in those situations. What else?
Do you have the quiz strips handy?
I can pull them up. You want to go over it?
There was a question on the third strip.
Okay. Let me pull it up real fast.
Okay. Let me know when you have it.
Actually. I remember where I have it at. Is it showing the screen now?
Yeah, we see your screen.
Okay. Is this it right here, Alex?
That one, yep.
Okay.
So I guess before I ask my question, would you call AVF equal to, like equiphasic or negative?
It's close. And so here's the thing. You know, we talked briefly about another way to calculate the axis when you got an equiphasic or near equiphasic lead. So what we know about it, even if you can't tell if it's quite more positive than negative, is that we know that the axis is going to be somewhere around 90 degrees from AVF, okay? In the ballpark of that, right?
Right.
Okay, so that if AVF is at positive 90, then I've either got an axis of 0 or close to 0 or close to positive 180, okay?
Okay.
So what I would do is I'd look to lead 1 and see if it's upright. If lead 1 is upright, that tells me that it's shooting over towards the left, not towards the right. So my axis is still in the neighborhood of 0 degrees, give or take some. And so if you use those more liberal measurements of -30 to about a positive 120, that some things will do, it still falls within the normal range. Now, if you were to say that was a little bit more negative and called it a left axis deviation, then I wouldn't fault you for that at all. Because it looks like it might be a little more negative there. I can't remember. Was it, what did we call it on the quiz? Well, yes, I would. Yeah, this looks with this complex right here. Is that showing up?
Yeah.
That with that one right there, the S wave looks. Huh? What did I do wrong?
Hey, Mr. Roberts,
Yeah.
in your book, it says that you have to look at the limb leads to determine equiphasic or not. So aren't your limb leads 1, 2, and 3?
All of so you have the bipolar and the augmented leads are all created from the limbs. So no,
Okay.
1, 2, 3, ABR, ABL, ABF are all. limbs.
Okay. All right. Okay.
Nice try, buddy.
Well, but in the book, it does say that the limb leads are just 1, 2, and 3.
The author's an idiot.
On page 55.
Okay. I see what you're saying.
So I thought if you do that and you look at 2, because that would be your most equiphasic, then it would be negative or it'd be left, correct?
So looking at the axis is figured in the frontal plane. So it's going to utilize the whole hexaxial diagram. Is that what you're talking about? Which leads are we supposed to look at?
Yes, but I'm asking you, like, if 1, 2, and 3 are just your limb leads and you looked at 2 being your most equiphasic, wouldn't that make it left axis deviation instead of normal if you did it that way?
So lead 2 is fair. I would say it's a little tough. It's a toss up between lead 2 and AVF, which would be most equiphasic, right? Which is kind of weird because they're about 30 degrees off of each other. Are you following me?
So,
You have to have left axis deviation for that one.
Well, honestly, I don't remember what the question was and the answer. What are we looking for here? What are we trying to?
it asks, okay, so the question asks, what is the axis for this one? But then the next question said, based on your axis for this one, what do you see? And the problem was it's either normal or left axis, and then the second question was either normal or left bundle branch block. But if you're saying this is normal, it's also a left bundle branch block. So how would you have both? I guess what people are wondering.
I got you. Well, let me look at this scoring on that. So the patient does have a left bundle branch block, right?
Correct.
Okay. So you don't have to always have a left axis deviation with the bundle branch block. Now it may happen, but it's not an always situation. What I can do is I can go back and give credit for normal axis on that one too.
Wait, so what was the right answer? Normal or left?
What do you think the axis is? I guess is what everybody's asking.
Well, here's the thing. It depends on what you want to use as your normal range, right?
Right.
So if you say 0 to 90, then I would say that based on at least the second complex here, I would call this a left axis deviation. If
Right.
I'm trying to be a bit more specific than Dubin and figure it all out, then I would call it normal. So you'll have argument both ways from different people.
All right, thank you.
I don't have the final answer. I think if you said left axis deviation or normal and you could explain why, then I think you both be justified.
Thank you.
Yep.
So would that also mean the follow-up question on that one with the, like, what's going on with them could also be normal?
Yeah, I think my thought process was you were supposed to be able to identify a left bundle branch block, but I'll look at it. I'll look at that. What else, folks?
I think chat question.
Chat question. Oh, man. All right. If a lead shows a P wave that has a positive inflection, why does the T wave usually show a positive inflection? Yeah, so just in general, I mean, I don't know why, but ventricular repolarization does tend to mimic atrial depolarization. So the P waves and T waves will usually kind of do the same thing. So most of them, the P wave is upright and the T waves are upright. AVR is the exception to that. So AVR is going to have an inverted P wave and an inverted T wave. V1, as we've already talked about today, has a negative portion to the P wave, and it also has an inverted T wave as a rule. So just a good way to remember it. I don't know that I can tell you exactly why, but that's just how it all shakes out. If you have an upright wave in 1 or AVF, yes, I would say if it's truly equiphasic, then yes. Yes.
The one up there in ABF, are you, in your opinion, is that equiphasic?
I'm sorry, you're breaking up. Say again. So, here, let's blow it up. So this one looks like it's 1, 2, 3, 4 blocks tall, and 5. If you're counting it and trying to be real specific, I'd say it's closer to 5 blocks deep, right? So, and that's in this one that looked close. If we look at this one, it's 1, 2, 3 blocks tall and 1, 2, 3, 4.5 blocks deep. So it's not truly, this one's not truly equiphasic. If anything, it's a bit more negative than it is positive. The easy answer using Dubin is left axis deviation.
Okay.
Does that make sense? But it's close. It's close enough that honestly, I don't know. I mean, if you argued it to be normal axis, I could get that, because if you're using, you know, it's approximately 90 degrees from that. This one, let's see, 1, 2, 3, 4. This one's actually, the lead 2 is almost more equiphasic. 1, 2, 3, 5. Well, it's hard to say. I wish I had the computer interpretation, but I don't have it. It's close. So are you saying you put normal on the quiz?
No, I didn't. I thought you were trying to say that it didn't.
You put left axis?
Yeah.
Okay. Yeah.
I can't remember the options, but I think the follow-up question, if you did call it left axis, then they would start messing with
Right.
that, because
Right. 'Cause what was the problem? What was the
I was working backwards. That, like, if
Right.
you call that normal, then you could argue that this was normal.
Right. Yeah. I'll look at it and see what I can do with it.
And then I guess, not to beat a dead horse, but if you were having problems figuring it out, can you use that shade-in method with multiple leads, like going from, like, normally you might look at 1 in AVF, but also add 2 in there with the diagonal to, like, kind of hone in?
You can, and I think, yeah, it's on page 182 of the book. It's called the 3-lead method. So it shows you can use another lead. I think it's adding adds lead 2 in there too. So page 182, called the 3-lead method. So you're using the same idea. You're using another lead. You know, it's 90 degrees off of that lead. Yeah.
Thank you.
Yeah. You can get pretty anal with the axis. In my opinion, you know, it's one of the 5 things that everybody says you should interpret. only when it's really obviously abnormal is it ever really somewhat useful. So on these, I don't know. I mean, this guy's got a left bundle branch block. So yeah, the axis is maybe a little off from that, but I didn't need the axis to make my diagnosis. The left bundle branch block was pretty clear, right? So the only time I could say where you get maybe a slight axis change and maybe it's not all that apparent and it's important is maybe a pulmonary embolism, but I'm not diagnosing a PE based on the EKG anyway. It might be some supporting evidence, but I'm still going to get CTA of chest or VQ lung scan or something else, you know. So I wouldn't sweat it too much. If you understand the basic idea of how to calculate an axis and some of the possible differentials when the axis is messed up, I think you'll be fine in the real world, you know, which is what matters.
So if that's the left bundle branch block, even though the only notch R wave is in one.
I'm sorry. Either come closer or speak louder or type it in.
So the R wave in one
Okay.
is the only notched one. I'm not scanning it right now.
Come with this.
And that's still a left bundle branch block, even though that's the only one. Didn't V6 also have to have a notched R? Or does it?
No. So for your bundle branch blocks, the two leads I would pay the most attention to are V1 and V6.
Is that deep S wave in V1?
Yeah. So for a left bundle branch block, you want a QRS that is greater than 0.12 seconds wide. Okay. Greater than or equal to. So if it's greater than 3 small blocks, then I've got a left bundle branch block. Or I've got, sorry, if it's greater than 3 small blocks, I've got the potential for it to be a bundle branch block. The next thing I want to look for is the morphology. So the morphology for a left bundle branch block is a totally complete negative QS wave in V1 and a total positive R wave in V6. Okay.
And the R wave
Go ahead.
doesn't it?
So page 182 in your book is where that's from.
Oh, I read it.
I'm sure you did. So the wide QRS complex greater than 0.12 seconds, QRS morphology, V1 has entirely negative QS, and then the ST2 wave discordance. So yeah, don't look over here at these leads for the for a bundle branch block.
So you don't.
No.
So you don't have to have a notched R wave at all then for it to be a left bundle branch block.
No. I know what you're saying now. Okay, so I follow you. So sometimes in V6, let's see if I can find it.
I just noticed that. I didn't see that before. It's better than a vagina.
Here, talking about this. Can you see my screen?
Yes.
So this is what you're talking about, right?
Mm-hmm.
Yeah, no, you don't have to have a notch. It's just going to be a wide, fully positive R wave. You don't have to have the notch. You might. The book says complex may be notched, so it doesn't have to be. But you're right. That's a possibility.
All right.
So that make sense?
Yeah.
Yeah. Okay. So yeah, you don't have to have these notches, but they can certainly be there, for sure.
So another cause of left axis deviation that was listed on that question was inferior MI. Would you just have not said it was that because in that thing it was not an inferior MI?
Right. Well, I went ahead and actually gave credit for both of those. Somebody had mentioned that, and so both inferior MI and the left bundle branch block were credited on the exam. But you're right, on the actual EKG itself, it was there was a left bundle branch block. So now I've lost my PowerPoint. Oh, we weren't looking at the PowerPoint. We were looking at this, weren't we? Okay. All right. What else?
Is it okay if I ask another question?
Sure.
I don't want to hold you up. So the equiphasic thing.
Yeah.
Can you? So if it's positive in one and equiphasic in the other, it's going to be normal axis. And if it's inverted in one of them and equiphasic in the other one, and like what 90-degree direction do you go? I'm overthinking it. You guys?
No, I understand the question. Let me see if I can pull up the x-axis diagram. I like that. I don't like that one. Doesn't work. Okay. All right, that's showing up okay?
Yeah.
Okay, so I think so we're saying that, let's see. A better one. Not really. Okay, so we'll say that ABF is equiphasic. Uh-oh. All right, so your question is if ABF is equiphasic, what?
Okay, so if ABF is equiphasic and one is positive, then it's going to be normal, right?
Correct.
So
essentially, so here's the thing. So you see my x-axis diagram over here?
yes.
Okay, so if ABF is equiphasic, what I know is that my axis is 90 degrees away from this. Makes it easy because it's 90. So it's either going to be 0, right? At a right angle from that. So my axis is either going to be 0 or it's going to be negative 180. One of those two. So how do I know which one it is? Well, I look at lead 1. Okay, so lead 1 is upright. So it tells me it's pointing in that direction. So the axis is over here. So it's really close to 90 degrees, 0 degrees. Now, since this is not perfectly equiphasic, it's not perfectly 0, but it's in this general area, right? And some of them will tell me that normal is all the way up to negative 30. So you could still be in a normal axis. Let me follow.
Yeah. Is there more?
So if one was not positive, it would be over here, which would not be normal. It would be a right axis deviation of some sort.
So if one was inverted, it would be a right axis deviation, is what you're saying?
Yeah, anytime one is negative, I mean, you can just remember this if you want to. Anytime one is negative, it doesn't matter what ABF is. If one is got a negative QRS complex primarily, then it's a right axis deviation.
No matter what?
It's gonna immediately go from this left side over here to the right side. When one is upside down, it shifts me over here to this side of the hexaxial diagram. So it's automatically going to be extreme right or right. So anytime one is mainly negative, it's going to be a right axis deviation of some sort.
Okay. Do you guys follow? Did you hear her?
No.
Your book says that you find the tallest R wave, and then you go towards that.
Yeah, you could. So in this example, the tallest R wave is where? ABL, right? So, no. Right? ABL?
What about 2? They said 2.
They said 2? This one sucks. So let's see. One, two, three. So this is 4 blocks tall. Hang on. This one's only like 2 blocks tall, right? 1, 2, 3. This one's 4 blocks. That one is 2 blocks.
No, she was talking about 2. Lead 2.
Oh,
Not one.
lead 2. Well, lead 2 is biphasic, so it doesn't. No. So what you want is the most upright. I may have to reword that. So it's not just the tallest R wave. It means there's no negative part to it at all. It's the most positive wave here as well.
Okay, that makes sense.
Okay. So this is the most positive. There's no negative deflection, and the R wave is super tall in comparison. Okay. So what that tells me is that my axis is aiming. If it's going to aim in one direction, it's going to be really close to ABL. Right? This is getting the biggest wave of depolarization is going in that direction. It's giving me the most positive wave possible. So it's telling me that my axis is somewhere up in this area, which still kind of fits with what we thought. We knew it wasn't exactly 0, but we knew it was kind of in this area. So ABL is most positive. So we're still getting an axis somewhere in this neighborhood, which is really clinically all that's going to matter. This is not, you're not going to kill anybody on this one, all right?
Okay, so what if lead 1 is aquaphasic and ABF is inverted?
Okay, so let's work it out. So lead 1 is equiphasic. So it's 90 degrees away from here. So it's got to be straight up or straight down, right? If ABF is negative, it tells me it's not going down here, it's going up there. So if I got equiphasic lead 1 and a negative ABF, my axis is going to be right up here.
Yes.
And?
Is there more? Wait, no.
This is right at -90. You're giving me a hypothetical situation.
Oh, okay. So, so then, yes, I understand that it would be up there. So
Okay.
would that be left or extreme right?
So you're right. It's kind of hard when it's sitting on the borderline. You probably just have to use your clinical context. Extreme right axis deviation is pretty uncommon, first of all. So the odds are it's probably some left axis deviation. The question is what's going on. Do they have left ventricular hypertrophy? Do they have a left bundle right spot? You kind of figure out maybe what it is. Maybe in the real world, if you're really worried about it and paying attention, you've got to look at differentials for both lists and kind of figure out what fits clinically with your patient.
That makes sense.
Yeah.
Are you going to rate all of our essay questions?
Yeah, I actually have already done that.
Oh,
Yeah, it wasn't terrible. It was fine.
it was terrible?
No, it was fast. The program made it easy. So you guys can look forward to more essay questions.
Oh. Did I type them 3 times again?
Can you what?
Katie wants to know if she can type it 3 times.
Oh, yes. I'll make you do it 3 times. It's a good learning tool.
I actually, yeah.
Yeah. All right. Anything else?
I think I kind of understand, but thank you.
You're welcome.
Thank
I'll if
you.
you need anything, and I will. Don't forget the videos, and I'll see you guys next week.
Okay.
Bye.
Bye. Oh, wow, you're huge now. My bad. Sorry.